In the heart of East Africa lies a nation with a deep commitment to improving its healthcare landscape through digital innovation.
Digitization is one of our 4 of the pillars of universal health coverage. So as a ministry, then we are leveraging on the technology to be able to provide services to Kenyans.
As early as 1972, Kenya's Ministry of Health recognized the need for a robust health information system. Over the next decade, the MOH led Kenya's health sector on a journey of coordination and development, decentralizing the health information system. But it wasn't until the mid-80s to early 2002 that Kenya witnessed a surge in the implementation of electronic health information systems, HIS, leading to a proliferation of non-standardized and interoperable systems.
Before 2010, we had multiple EMRs existing in the country, and they were largely driven by the need for data and reporting. The Ministry of Health came in and developed EMR standards and guidelines. Those guidelines were launched, and we conducted an assessment around the same time and just found only 4 EMRs were conforming to those standards and guidelines.
The results of these assessments paved the way for a new era of standardized national reporting systems.
After NASCOP selected the electronic medical record systems, Palladium under the Kenya HMIS project was mandated with expanding these EMRs to conform with the guidelines a bit more.
Most facilities have some form of technology that they use. So now we want to have an interoperable system where all areas, all facilities being able to get information, then they get into a government superhighway where all this information then can be linked so that there is a client registry that provides the records of a patient.
The devolved governance established in Kenya's 2010 constitution further emphasized the importance of tailored HIS implementation at the county level.
I can track 3 systems that we used to migrate information. The first system was from CPAD to IQ Care, which still we lost a lot of information of the patient. Now we had to go back again to the files because things like registers where the files could maybe be documented were still in the hands of other people. Kenya EMR came in place in the year 2020 around November, and we managed now to completely migrate our patient data from the old IQ Care system to the Kenya EMR.
Initially, we would move through files. So you'd peruse through the files. Of course, some leaves can lack off and disappear, giving now incomplete information. But with the advent of EMR, just with a tablet or a laptop, you are able to have the CCC number of a client, and you click just to the client name after entering that unique code. Then you are able to access the client, and you have everything at a glance.
At Rachuni, we have the IPD, and we also have the MCH and also the VCT. But when I click at the Kenya EMR, I can be able to view the register and view all the clients who were tested from that, from all service delivery points. And I can be able to analyze and put them as per the modalities that are supposed to be captured.
We are able to give at least accurate information about the clients we serve in Homa Bay. During manual documentation, the staff, there's a lot of documentation done, and you find due to fatigue and all that, you find some columns, one misses to document. Now having the system, it has some restriction. You can't move if you don't complete this. This one allows us to capture all the parameters, all the variables that is required.
Digitization is not cheap. It's very expensive, it's capital intensive in terms of hardware and software. So for this reason, we've collaborated with the different partners to ensure that the digitization agenda is articulated.
We have mapped out all the facilities in the country, and the total number of facilities that we have in the country is 1,430. These 1,430 are all going to be grouped into 315. So these 315, those who want to seek medical attention, the doctors or the medics will be able to access their records.
So we have trained both technical, that is the nurses, the clinical officers, the lab technicians, the pharmacists, the doctors, but also the non-technical, really to be able to uptake these EMR services.
From 2012 to 2015, these EMRs were rolled out using US President's Emergency Fund for AIDS Response PEPFAR. By 2016, there were over 642 EMR facilities using IQ Care, Kenya EMR, eCare, and AMRS for use by data clerks for data capture and reporting in large HIV clinics.
The HIV program migrated from using open source EMRs. The EMRs have now clinical decision support systems. They are also able to report. So we have seen an improvement in the data that we are now utilizing to make decisions for our clients.
All things are synchronized into one, meaning at a visit like today, you're able to see all the services a client is due. You're able to send your client to the lab without using the hard copy paper. The client can come back and then you send to the pharmacy. And you're able to see the due services.
We were able to expand the EMRs to over 2,000 facilities that provide HIV care across the 44 counties that currently have a higher burden of HIV in Kenya.
The support is more on HIV, but now there's that kind of scale up. Like now we are doing MCH, the TB, and other departments. I'm looking forward where we'll have this system in the inpatient ward.
The EMR systems are integrated with the Health Information Superhighway through the National Client Registry (CR), National Health Data Dictionary (NHDD), and the National Shared Health Records (SHR). The National EMR Data Warehouse (NDW) was developed in 2012.
Through CDC funding, Palladium developed a national data warehouse that is stationed in NASCOP and owned by NASCOP. So the National Data Warehouse currently hosts data for over 90% of patients who are receiving HIV care services. This data is securely available to NASCOP and is de-identified in line with data protection laws in the country.
We have developed the digital health bill because there are certain data that has to be shared. We want this data of our patient to be accessed where the patient has given the rights to the facility to access that data. So this data will be stored in what's called the patient registry.
These systems are expected to drive critical reforms in health service delivery.
We are working together with partners to ensure that we deliver the digitization of health. Therefore, as Concert and Police, we've provided that cloud compute environment, which now ensures that the systems are able to interoperate and therefore provide a more synergistic approach to digitization of the health system.
The COVID-19 pandemic acted as a catalyst for innovation, leading to solutions like Chanjo KE and other disease surveillance digital health tools. These tools are now being modernized to support routine health service delivery, transforming into routine immunization information systems and electronic immunization registries. This revolution further spurred the strengthening of cloud EMR.
So one of the things that we worked on was to establish how this data would come in, and this was through digitization of the tools that we used using the cloud EMR. And the impact of this has been you're able to see what is happening within the 28 facilities and make decisions, probably when interventions need to be put in place.
Being one of the best systems, we can say it has made the overall job easier. The patient's time has really gotten shortened because we are seeing patients in less than 15 minutes.
We have already developed an ERP, an enterprise resource program that is going to encompass and digitize using technology most of the county services, including a hospital management system. The stocks in every facility, including our level 3 facilities, that can be seen at the touch of a button in every facility.
We have organized the facilities in a primary care network. is a hub and spoke model. So a specialist sitting at level 4 hospital is able to provide support to a patient who is in a spoke that could be a level 2 or a level 3 hospital.
The future holds the promise of artificial intelligence, where AI-enabled digital health systems are emerging to further enhance healthcare delivery.
We are leveraging the artificial intelligence and machine learning to actually start to predict trends for our patients. For example, like in testing, we're using machine learning to sort of like predict, like if a patient is testing several times, we're able to tell, test this patient, or maybe this patient needs to be linked to other services.
So artificial intelligence currently has been implemented in over 1,000 facilities, and NASCOP has been at the core of guiding that process in collaboration with other implementing partners and experts in machine learning and data science.
So we shall be working with other government agencies as things evolve, as AI evolves, and we are going to see a simplified kind of lifestyle where information is available and people are even able to live healthy, promote health and wellness based on availability of information on the digital gadgets.
Kenya's commitment to health digitization is paving the way for a healthier and more connected nation through committed leadership, partnership, and great determination to the realization of the highest attainable standard of care for every Kenyan.
I would really recommend to all the stakeholders really to join hands, really to support the Ministry of Health and National Government in rolling out the primary care networks, in rolling out the digitization, because the only way we shall be able to achieve universal health care.